This is Debbie Bucher for Parkland College, and this is for Medical Surgical Nursing 2, third semester. This is with regards to renal disorders. Next are the objectives. So once again, we're talking about another homeostasis system that our body uses to maintain homeostasis, and that's the kidneys. The kidneys help to regulate the composition and volume of the extracellular fluid by excreting metabolic waste, excreting excess solutes and water, or conserves them. Kidneys also help to regulate acid-base balance as well as blood pressure. And with aging, kidney function changes, and the elderly are more prone for kidney disorders as well as kidney failure. The kidneys are divided into 3 different areas: the cortex, the medulla, and the renal sinus. The cortex is where the nephrons are located, which is the functioning unit of the kidney, and our kidneys contain about 1 million nephrons. And patients who experience renal problems will most likely have fluid and electrolyte imbalances. Intake and output is really important to assess with these patients as well, and daily weights. And again, fluid and electrolyte disorders are going to occur with anyone with having acute kidney injury or chronic kidney failure. Next is just a couple pictures of the kidney and the different areas of the kidney. And then this is a picture of the nephron of the kidney. And next is just a comparison of acute kidney injury and chronic kidney disease. As you can see, acute kidney injury occurs rather suddenly, where chronic kidney disease will more often than not just develop gradually over the course of many years. Diabetes is a big cause of chronic kidney disease, and acute tubular necrosis is a cause of acute kidney injury. Where you have elevation in serum creatinine, particularly an acute kidney or a chronic kidney disease, you'll see kidney damage over the course of more than 3 months. Now, hopefully, acute kidney injury can be reversed, where chronic kidney disease is just progressive and irreversible. And acute kidney injury can detect just a slight deterioration in kidney function, or it may be rather severe. And again, acute kidney injury is characterized by a rapid loss of kidney function. And you will see a rise in serum creatinine as well as a rise in BUN. You may also see a reduction in urine output. And again, you're going to see azotemia, which is an accumulation of nitrogenous waste, which is what produces a urea, and usually that's excreted via the kidneys. But of course, in this case, when you have kidney dysfunction occurring, then the BUN will also be increasing as well. And yeah, kidney failure, whether it's acute and or chronic, the kidneys are just not operating the way they normally do and able to filter out the waste and the fluid. And again, acute has an abrupt onset, where chronic will develop over the course of several months. And there's about 8 million people in the United States that have moderate to severe kidney dysfunction, and about 400,000 people who are receiving dialysis, and about 80,000 people are waiting for kidneys for kidney transplants. And the cost of end-stage renal disease for all these patients is approximately $33 billion. So it does cost the consumer quite a lot of money for any of your chronic diseases, really. So, and patients who experience acute kidney failure, again, it occurs very rapidly, and it does have a fairly high mortality rate in people who are in the hospital and who are in the ICU. For patients who are in the ICU with kidney issues, acute kidney injury, they can have a high mortality rate as much as 70 to 80%. So it is something that we need to look at and take very seriously for these patients. And again, as I said, acute kidney injury will happen rather quickly and can maybe be just a slight condition to a very serious condition where they are in the unit. You will see again increases in BUN and creatinine, and urine output may be less than 40 cc's an hour, but actually could be normal in some cases. And there's 3 causes of acute kidney injury: prerenal, intrarenal, and postrenal. Prerenal is anything that would be decreasing fluid volume circulating to the kidneys, such as dehydration, heart failure, decreased cardiac output, that sort of thing. Anything that you're congestive heart failure, anything that's going to reduce the flow of blood to the kidneys, which can then cause kidney injury. Intrarenal is where actual damage can be occurring to the kidney, and acute tubular necrosis is the most common cause of acute kidney injury, and it's the result of ischemia, nephrotoxins, or sepsis. And ischemia and nephrotoxicities are responsible for about 80% of the causes of acute tubular necrosis in this case. And then also so there's intrarenal or from acute tubular necrosis, and there's also postrenal. That involves some sort of mechanical obstruction in the outflow of urine. As the flow of urine is obstructed, urine refluxes back into the renal pelvis, impairing the kidney function, and then that's what occurs. And stones can also cause this, trauma, tumors, prostate cancer. Again, anything that's going to produce that blockage is what we consider post-renal cause. So those are important to remember. So in your Lewis book, there is the rifle classification of acute kidney injury. Risk is the serum creatinine is 1.5 greater, or the filtration rate decreases by 25%. Urine output is less than half a cc per kilogram per hour for 6 hours. Injury phase is the filtration rate is decreased by 50%, serum creatinine is increased by 2, urine output is less than half a milliliter per kilogram per hour for 12 hours. Failure constitutes the serum creatinine increasing by 3, or filtration rate decreased by 75%, and the urine output is 3 milliliters per kilogram per hour for 24 hours. And then loss is persistent kidney failure with loss of kidney function for more than 4 weeks. And then end-stage renal failure is complete loss of kidney function for more than 3 months. Acute kidney failure, again, these patients can appear very ill and weak. They may be dehydrated. They may complain about having headaches, oliguria, drowsiness, tachycardia, crackles, irritability, drowsiness, dry skin, nausea, and vomiting. We usually look at labs associated with this. So the patient may have protein in their urine. RBCs may be down due to glomerular dysfunction. And you may see WBCs. Actually, you may see RBCs and WBCs in the urine as well as protein. The serum creatinine and BUN increase rapidly, all the while the filtration rate will decline. And you'll see potassium increases, anemia, because there's reduced RBCs being made from the decreased erythropoietin secretion by the kidney, because the kidney's not working very well. Metabolic acidosis can then occur. They may do CAT scans or MRIs to try to determine the cause. Ultrasound and biopsies may be used as well. So treatment of acute kidney injury is you want to restore and maintain kidney function, give medications, IV fluids, blood volume expanders to help perfuse the kidneys. Dopamine may be used to help increase perfusion to the kidneys and increase cardiac output and dilates blood vessels of the kidneys. Furosemide and mannitol may be given to excrete toxins and help increase the output and decrease the edema. Antihypertensive medications are more than likely going to be given to control the blood pressure. Proteins are limited in the diet because you don't want the breakdown of proteins to increase the urea, because your kidneys are not able to filter out the urea as well, thus your BUN increases. And in some cases, in acute kidney injury, patients may indeed require dialysis for a length of time until the kidneys can recover. So the first step you want to see, possibly, what is the cause? Is there intravascular volume issue? Is cardiac output decreasing? Are they, having too much, maybe too many diuretics, thus contributing to dehydration? Or maybe your patient could be hemorrhaging as well. Hyperkalemia is one of the most serious complications in acute kidney failure because it can be life-threatening because of dysrhythmias. And of course, we already know about that. You may be giving insulin, glucose, Kxalate, all the while to help decrease the levels of potassium. And maintain fluid balance. You want to maintain adequate blood flow to the kidneys, again with IV fluids or blood products. And again, if it is very serious, they may need to do hemodialysis. Good nursing care, of course, meticulous intake and output, daily weights, checking vital signs. Patients may prefer to be semi-filers to help promote respiratory and cardiac function. Of course, you're going to be monitoring the electrolytes, especially the potassium, and also sodium may be decreased because of the fluid retention, so it's hemodiluting the sodium, and you may see increased phosphate. These patients more than likely will be on a fluid restriction. You'll be administering medications, some medications with meals to decrease fluid intake, good skin care, and of course, good infection control, as infection is the leading cause of death in patients in acute kidney injury. And again, daily weights and observing their urine output and their intake is really important to know how their fluid balance is doing, as well as their electrolyte balance. And the elderly, again, they're more susceptible than younger adults due to dehydration and due to the use of polypharmacy, impaired function of their cardiovascular system, and also the systemic disease of diabetes and hypertension. The aging kidney is less able to compensate for changes in fluid volume and cardiac output. And patients older than 65 are more likely to have acute kidney injury, and also then are less likely to recover as well from acute kidney injury. Dehydration is a predisposing factor and tends to occur more rapidly and more frequently in older adults. Dehydration, again, can occur from polypharmacy, diuretics, laxatives, acute febrile illnesses, or immobility from being bedridden. And of course, mortality rates are higher for patients over the age of 65 with acute kidney injury. And we also have end-stage renal disease, which is where the kidneys are no longer able to maintain an internal environment that will sustain life. Damage to the kidneys is irreversible. About 1 out of every 9 Americans has chronic kidney disease. And of course, many people, over 500,000 people, may be receiving dialysis. And of course, many of those are on transplant list. And of course, to gain a transplant is the percentage is not very high. And more than 26 million American adults have chronic kidney disease. So again, the next is the different stages of chronic kidney disease. There's stage 1, stage 2, stage 3A, stage 3B, stage 4, and stage 5. I won't list, I will not speak on all those, but you can look at that in your book, though, that it is helpful to know the different stages of chronic kidney disease, as well as, of course, with acute kidney injury, knowing the different causes and the phases of acute kidney injury. And now, again, chronic kidney disease, it's presence of kidney damage for more than 3 or more months with progressive kidney dysfunction, and usually we'll see proteinuria 2 or 3 times in a 3-month period. Renal mass may decrease, there may be loss of nephrons or deterioration of the glomerular filtration, as well as kidney function. Kidneys are unable to excrete the metabolic waste and regulate fluid and electrolytes. And glomerular sclerosis and interstitial inflammation with fibrosis can also lead to declining kidney function. And some of your other causes are, again, diabetes, hypertension, glomerular nephritis, and cystic kidney disease. All can be contributing factors to someone with chronic kidney disease. Proteinuria, though, usually is the first sign of kidney damage. And of course, your glomerular filtration rate is the best indicator of kidney function. And as BUN and creatinine rise, and creatinine is really considered the most sensitive as it is produced constantly in the body. BUN increases, and that is from the breakdown of urea that your kidneys are not able to filter out. But also these patients, you may see BUN increases because of protein intake or steroids or that sort of thing. And these patients may complain about having nausea, vomiting, lethargy, fatigue, headaches, and that sort of thing. So anemia develops due to inadequate erythropoietin, which is produced by the kidneys. So you have less production, and then you have usually the erythropoietin is stimulated by the bone marrow to produce RBCs, but of course you have less functioning of the kidney, so they're not going to be able to do that as well. So that's why you see anemia in your chronic kidney failure patients. But you can also see anemia because of this in your acute kidney injury as well. So you can see it in both. So backing up to that previous slide with talking about the platelet dysfunction. So in chronic kidney disease, there is a platelet dysfunction in uremia, and it impairs the release of the platelet factor, which puts these patients at a higher risk of bleeding. So these patients are at a higher risk of bleeding. So I wanted to make sure you understood that. So we also see an increase in the electrolytes, of course, as well as fluid. So we're going to see an increase in magnesium. Serum pH is decreased because, of course, your acid is increasing. Your bicarb is decreased because of metabolic acidosis. And again, like I just talked about with the erythropoietin, hemoglobin is also decreased, and BUN or urea is increased. And again, we have the calcium and phosphorus imbalance. There's usually, and again, we have the reciprocal relationship. And of course, in chronic kidney disease, we see an increase in phosphorus. So we have more calcium that's needed to bind with the phosphorus. That's causing the calcium to decrease as well, because it's having to combine with more phosphorus, because more phosphorus is being retained because the kidneys are not able to filter it out. And again, I've already talked about anemia. You can also see vitamin D decreases in chronic kidney failure. Vitamin D is normally produced by the kidneys, but of course that decreases as the renal failure continues and worsens. And this is just a chart that talks about the different manifestations of chronic kidney disease. Of course, these patients will develop fluid retention and may develop, of course, oliguria or anuria, no urine output. And as the glomerular filtration rate decreases, you'll see a rise in your BUN and serum creatinine levels. These people will have nausea, vomiting, lethargy, fatigue. Impaired thought processes and headaches may occur. So again, I talked about some of the manifestations. Chronic kidney disease may not be found often until uremia is found in the blood. And again, I've already talked about the nausea, fatigue, weakness. But they may have a uremic fetor, which is a urine odor of the breath. And people that are a diabetic that are on insulin or other medications, when your kidneys are not filtering out that medication as well, then they may need less of the medication, such as insulin, or less hypertensive medication, or whatever it may be, because it remains in the bloodstream for a longer period of time due to the decrease, glomerular filtration occurring. So you want to watch medications and make sure they're not getting too much. More than likely, you'll have to decrease the dosages. So hyperphosphatemia and hypocalcemia occur, like I said. You're going to be treating the increase in phosphorus with medications that bind the phosphorus in the GI tract. Calcium carbonate, such as Oscal and Foslo, are used. These drugs have calcium in them, but if the patient is at risk for hypercalcemia, then you may not want to use these. The physician may want to order something different. If hypercalcemia is present, then they'll give a phosphate binder such as Renal and versus something with calcium in it. So you want to get phosphate binders such as Renal with food, and calcium carbonate or calcium acetate as well as with food, but again, this is for hypercalcemia. and yeah, take with food because they may cause nausea. If not, mechanism of action is in the GI tract, so you do not want to crush or break these pills if you don't have to. So in some cases, patients may require uh, a medication called Sensipar or Senecalcet to help control secondary hyperparathyroidism if your patient does indeed have that. And next, treatment of chronic kidney disease, chronic kidney failure, is you want to maintain kidney function for as long as possible. And more than likely, these patients are eventually going to need dialysis, and you'll be giving medications such, again, as Renal, hypertensive medications, Epigen to treat anemia, ACE inhibitors such as Lotensin, Capitan, and Vasotec, Cozar, Diavan, Benicar can all be used, and they all help to decrease the blood pressure and also slow the progression of chronic kidney disease. Our overall goals are to preserve existing kidney function, reduce the risk of cardiovascular disease, prevent complications, as well as providing for the patient's comfort. Dicar may be also used as well as calcium insulin and glucose may also be used to treat hyperglycemia as well as to translate. You may be giving folic acid and trying to deal with the anemia. Diet, such as increased carbohydrates and decreased protein, so you have less protein breakdown, thus less causing the to go higher. Water may be reduced, maybe on food restriction, and no salt substitutes, as these are high in potassium, which we already are at a risk for increasing potassium because of the body's ability. And again, good nursing care, assessing heart and lung sounds, skin color, edema, weight, bowel sounds, meticulous intake and output, fluid restriction, monitor BUN, creatinine, glomerular filtration rate, CBC, and electrolytes. Obviously, assess the effectiveness of the medications that you're giving, monitor diet and intake, again, increase carbs and decrease protein, assessing the risk for infection, and education on dialysis if it looks like dialysis may be needed. And dialysis is used to remove fluid and waste that build up in the blood since the kidneys are unable to maintain. If they do need to have dialysis, hemodialysis is one form of dialysis that it may be used. It's usually performed in a dialysis center 3 times a week for 3 to 4 or 5 hours. There's a higher risk of complications with long-term hemodialysis. You need to access the patient's bloodstream. If short-term, a double-lumen catheter may be inserted in the hospital. Longer-term, an arteriovenous fistula may be used to bring together the vein and artery, or an AV graft may be used using Gore-Tex to bring together the vein and artery. And the most difficult problem, of course, in hemodialysis is maintaining vascular access. You need good blood flow and access to a larger vessel. And again, it's just used to help maintain the body's fluid and waste. And again, if the patient does receive a kidney from a kidney transplant, then the patient can stop dialysis. Although, like I said, the odds of getting a kidney transplant are not very high, although it does happen. So again, you have the AV fistula, the AV graft, as well as the central line catheter if they're in the hospital needing to have dialysis done for a short period of time. And both of these, the fistula and the graft, you usually do have to wait maybe anywhere from 6 to 8 weeks to allow that to heal, to be able to then withstand the needles that are used for hemodialysis. So it's not overnight. It'll usually take several weeks for these things to get to the point where they are mature enough to use. Patients are encouraged to do arm exercises as well as to increase the size of the vessels to tolerate those needles that are pretty big. You don't want to take blood pressure on the arm with the fissure of the graft because it could cause either one of those to clot. So you do want to be very careful. So again, anywhere from, usually 4 to 5 weeks, but if it is mature enough, it may be able to be used after 2 weeks, but more than likely it's going to be longer than that. So that's hemodialysis. Hemodialysis can be very time consuming. Patients will need to present to these centers usually 3 times a week. And again, for, maybe roughly 3 to 5 hours. So you can see that on those days, that's really about all those patients have time to do is dialysis. So it really does affect their quality of life. So there's also another form of dialysis called peritoneal dialysis. It's where the peritoneal membrane serves as a dialyzing membrane. The warm dialysate fluid is instilled into the peritoneal cavity via a catheter in the peritoneal space. Dextrose is the osmotic agent or ingredient to draw the waste and fluid into the dialysate, and then the fluid is then drained by gravity into a sterile bag. The dialysate time and the frequency is ordered by the physician. There's less risk for the patient because it's done usually on a daily basis and done more gradually and more consistently. And peritonitis is the most common complication. Fever, unusual color or cloudiness of the used fluid, and redness or pain around the catheter are all indicators of infection. So good assessments are needed as these patients come in and you're assessing their peritoneal dialysis sites, catheters. So you have to have a patient that's motivated doing it at home, and a patient that's going to keep their things in a clean environment, and they know how to do clean versus sterile technique. The dextrose is ordered at either 1.5%, 2.5%, or 4.25%, according to the patient's height, weight, and their tolerance. And people can do the peritoneal dialysis up to 4 times a day, or they can choose to do it overnight via machine. And then those people are able to return to work and maybe even be able to work a full day, if not half a day. So they don't have to worry about doing the peritoneal dialysis, during the day. They can just focus on doing it during the night via the machine. So that does help out. And the people that do it usually like it pretty well, and it does seem to meet their needs. So these therapies are used for the unstable acute kidney failure or chronic kidney failure patient who cannot tolerate traditional dialysis. And again, most of the time these patients are in the intensive care unit. This type of dialysis doesn't require machines. It could be initiated quickly, and they just need access to the circulation via a central line for the blood to pass through a filter, a special filter, hemofilter. And then it's returned to the patient via the same catheter. And it just allows for a more continual, slow removal that's much better tolerated by your unstable patients. But all the while, you're still removing the uremic toxins that are building up. Assess vital signs, weight, assess vascular dialysis device, AV fistula graft, feel the vibration, hear the through. When you feel it, you can feel the blood it feels like the blood is rushing through it. Also, nursing care, monitor labs such as the BUN, creatinine, the hematocrit, and electrolytes and hemoglobin. Assess for mental status changes. Hypertension may occur, and there could be some pretty rapid changes in the BUN, pH, and electrolyte levels. Assess for muscle cramping, hypotension, bleeding at the access site, chills, fever, chest pain. And of course, they need lots of close individual assessments during dialysis. You're going to be assessing for respiratory and cardiac issues for these patients and assessing fluid and electrolyte imbalances, monitoring lab work. You may be administering blood, assessing blood pressure. Of course, good infection control measures are really needed. Monitor medications and provide support to these patients and their families. So if your patients need kidney surgery to remove it for kidney cancer or maybe a kidney transplant, or to remove calculi, They may need to insert a drain into the kidney, which is called a nephrostomy tube, and that's to help keep the everything open and allow for drainage. And of course, no matter why they're having the kidney surgery, good education, of course, is needed, but particularly if you're having a kidney transplant done. Maintain for a patient having kidney transplant, obviously good assessment, maintaining catheter function. You may be checking output every 30 to 60 minutes, assessing vital signs, maintain fluid replacement, diuretics if needed, and of course monitoring the fluid and electrolyte and renal panels, assessing for hemorrhage, and again just looking at your labs, pain relief measures, promoting airway clearance, effective breathing, monitor intake and output, monitor for signs of bleeding, encourage leg exercises, strict asepsis with catheter and appropriate teaching, of course, in providing care. And the most common cause of transplant failure is rejection. Hyperacute rejection occurs at the time of transplantation or within 48 hours. But although this is rare due to the careful cross-matching that is done prior to surgery, rejection is usually found on the X-ray showing enlargement and/or biopsy. And rejection or infection can occur up to 75% of patients in the first year. Immunosuppressant medications may increase the risk of infection as well. Hypertension can occur after transplantation and occur up to 70% of patients. And this can be due to the drugs that are given for anti-rejection, such as prednisone, cyclosporine, and tacrolimus. So renal transplantation nursing care, again, monitoring fluid and electrolyte balances. Delayed graft function can occur in about 20% of patients, and dialysis may be needed until the kidney starts functioning. Good patient and family education, teaching signs and symptoms of rejection or infection, and have them report to doctor if fever over 100 degrees, any flank pain, edema, or shortness of breath, any sudden weight gain, or changes in voiding patterns. After surgery, these people will be having activity limitations, no heavy lifting over 20 pounds for the first 6 weeks, regular exercises, and most patients can return to work after 6 to 12 weeks of healing. Again, monitoring weight, cholesterol, as steroids can increase appetite. Steroids and the cyclosporine can increase the risk for hyperlipidemia, so you're going to want to watch this. Avoid those foods with hidden sources of calcium. Follow medication instructions. And renal cancer, just talk a minute about this. Only about 10% of patients, only about 3% of all cancers in adults will account for renal cancer deaths. 10% of patients may have signs and symptoms of hematuria, pain, and a mass in the flank area. Diagnosis will usually be done by cystoscopy or angiogram, or CAT scan, or ultrasound. A radical nephrectomy is usually going to be indicated removing the tumor in the kidney, the adrenal gland, as well as any lymph nodes, fat, and fascia. Most renal cancer does not respond to chemo, but declines after, but sometimes after surgery, chemo will be given in addition to the removing the kidney. And again, just good nursing care. Encourage coughing and deep breathing, changing positions, getting them up and walking them around, teaching patient about lifting instructions and signs and symptoms of infection, and also maintaining their appointments and any lab work that they need to have done. So just, good assessments with these patients who have a kidney transplant done. Again, we don't really see this done in a majority of patients because it just doesn't happen very often, but I know of a man in the area was on a transplant list, and actually a physician, and actually one of his patients had a close match to him, so he was able to donate one of his kidneys to this physician. And the last time I heard, he was doing quite well and working full time and doing really well. So it just doesn't. Like I said, the kidney transplants can be really good, but of course there's not a high number of people who actually get to have a transplanted kidney. So just kind of one of those things that's hard to come by for obvious reasons. So, well, this concludes going over chronic kidney disease and acute kidney injury, as well as the different types of dialysis being done, mainly hemodialysis and peritoneal dialysis. And this concludes this renal disorders lecture. Thank you.